Okay, hope everyone had a good lunch and getting into the afternoon session. We're in the home run here. Our next panel will explain California's prescription drug monitoring program. A program that's recently been in the news a great deal, yet it's a tool that we're really kind of unfamiliar with. Mike Small is with the Department of Justice and is in charge of the program. Dr. Gregory Polston has a really impressive CV. He's Associate Clinical Professor of Anesthesia at UCSD, Associate Clinical Director of the Center for Pain Medicine at the UCSD Medical Center, and Associate Clinical Director of Pain Medicine at the VA Medical Center in San Diego. Darlene Fujimoto, pharmacist we've met earlier today. Without further delay, please join me in welcoming Mr. Small, Drs. Fujimoto and Polston, who will explain and demonstrate the features of the state's CURES program.
Good afternoon, everybody. You probably heard that the legislature had defunded CURES, so we're at the same time that the California Bureau of Narcotic Enforcement and my own bureau, the Bureau of Investigation and Intelligence, were also defunded. So I'll tell you what kind of manager I am. They put me out of work, and then they decided to make me in charge of the defunded project. CURES, our mission, as I've inherited it, is to eliminate pharmaceutical drug diversion while promoting legitimate medical practice and quality patient care. So we really don't want to infringe in any way on legitimate medical practices. I know that a lot of concern has been expressed to me about this might have a chilling effect on legitimate prescribing, but some of the egregious examples were spoken about already, and I'm not going to go over those. But I think it's fairly clear we can separate the sheep from the goats pretty easily and not really affect well-meaning or well-practicing individuals of any kind of a clinical endeavor. I can never remember what CURES means. It's one of those acronyms they built and then found the words for it. That's readily evident by the substance isn't even accounted for. But it means Controlled Substance Utilization Review and Evaluation System. But CURES does sound great, and I like the name, so I'm keeping it, at least while I have the watch. The program is the longest continually running program in the country. New York actually started one 2 or 3 years earlier, but for whatever reason, they had a 4-year gap at one time in the early 40s, so California gets the crown for the longest continuously running program. And anybody over the age of 40 knows about the old triplicate prescription forms that constituted that program up until the 1990s, late 1990s. CURES did replace that, 1998 to be exact. However, there was not a electronically facing inquiry system available to you practitioners until 2009. So it wasn't really very timely before. You'd have to mail in a request for a report, and then we'd mail it back. So by that time, your patient was either gone or dead. So the relevant provisions of law are, there is good body of law on this. Of course, HIPAA is at play. California Confidentiality of Medical Information Act, also Information Practices Act, and then the CURES legislation itself, which is a very nice symbiosis with the Information Practices Act, because the Health and Safety Code basically gives me exemption from the Information Practices Act, so I get to tell reporters and lawyers that they simply have to go to the pharmacies themselves and try and get the prescriptions from them. So they won't get it from me. I routinely deny subpoenas, at least 3 or 4 a day. The authorizing portion of the Health and Safety Code affecting you clinicians is 11165.1A1. Says that the prescriber or the dispenser can apply with me, with my department, and in turn, once your application has been processed, you can electronically access the system and you can obtain 3, 6, or 12-month patient activity reports. We've accumulated over 100 million entries. Well, since we've gone back to 1939, that's not a surprise. We had more than 800,000 electronic requests during last calendar year, and I think we actually responded to more than 8 or 10 of those. That's not quite accurate. You can get 3, 6, or 12-month reports, so you select what length of report you want. And if your guy's been to 28 doctors, that system might even crash on you, because I've seen some patients that had 56-page reports with over 1,200 prescriptions in a 3-year period of time. It can get lengthy. The way the system works is all dispensers are required to report dispensation data on Schedule 2 through 4 substances, at least on a weekly basis. Most pharmacy IT systems do that far more regularly, almost instantaneous in some cases. But at the statute, which is old, requires at least weekly, but that's really obsolete. Unfortunately, or fortunately, the inquiry into the system is completely voluntary, and I like generally people have freedom of choice, but as you'll see, there is, out of a potential 212,000 prescribers and dispensers in the state of California, and this is as of June of last year. As of last week, we only had 12,967 active registrants.
Mr. Small, can we ask a quick question? How many people are registered for Cures? Good. Obviously, we have interested folks here today because you exceed the statistic. Obviously, 6.09% participation does not really constitute an effective prevention and intervention program. So I'd ask you to consider that, and if you have not registered already, do so, and maybe even convince your colleagues to do so as well, because that's not a real figure I'm proud about. Registering to the system is quite easy, well, or not. I will not deny that it is an old and clunky system, and it is very possible that this fiscal crisis we face right now is an opportunity in hiding. I've recommended a $2.5 million figure for the legislature to consider for a rebuild, which would include such features as making the system available on an interoperative basis with the major healthcare systems of the state, so that by querying all the scheduled patients for the next day, when the physician walks into the room to see the patient, the data will be right there with the EHR, and when it's right there in front of you, it hopefully it'll be hard to ignore, and hopefully someone might actually take a look at it, and maybe take note if your patient's going to 27 other doctors for the same drug. To apply is, like I say, it's fairly simple. You go to OAG for Office of Attorney General.ca.gov/cures-PDMP, and you select whether you are a pharmacist or a practitioner. It has this real deceivingly easy form to fill out, deceivingly appearing easy. Take note, when you answer those security questions,
you better write them down somewhere, and you better write them down exactly as you input them. This crazy system is case sensitive, it is punctuation sensitive, it is sensitive that if you don't respond to the questions exactly as you input, you'll never get back in. And I spend at least 3 hours of my day helping people, with this very problem, because whatever sadist designed the system initially, they didn't make an easy forget password routine or anything. Oh no, let's not do anything like that. Let's waste human time and frustration on making it as difficult as possible to try to get into the system. You're welcome to call me always. I love spending 3 hours of my day that way. But it is important to me to have as many registrants as possible. And for that reason, I will help anybody that calls me, or I'll see to it that somebody helps you. I have a few bums in the back I give some peaches and pears to, and they help out once in a while. So, because I don't really have any staff. So that's the deceiving part. You push the send button, and all that happens electronically is my system then sends you a query confirming your email address. So, by God, we got to have your true and real email address, okay? Then the rest of it's manual. You have to print this application out, you sign and date it, you have to get copies of your driver's license, your DEA certificate, and your clinical license, be it a pharmacy or physician. And then you have to go find your neighborhood notary and get it notarized, and then you can mail that all in to me. And then when me or one of Joe or his brother Joe finally process it, then you'll get an email that with a password establishment routine. You complete that, and then you're finally in. So, good luck, but please try. Please try. As I say, this is an opportunity in disguise. We can actually have a system that this could be entirely electronic, user-friendly, and deliver you some very valuable data that can, in fact, be a help to us all. And I hope to get there. So if you happen to know anybody who knows anybody in the legislature, let them know it's not a bad idea to spend a paltry $2.5 million, and we might have a good system that might help the community. Okay, let's presume you got in somehow. If you want to inquire, you go to pdmp.doj.ca.gov/pdmp/index. Now you can get the inquiry screen, or at least you can log in, and then you get to the inquiry screen. And you simply fill in your patient's last name, first name, date of birth. I would not fill anything else in. That could actually limit your search and not give you all the possibilities. So again, it perplexes me why some things were done the way they're done, but it is what it is because I can't change it yet. Okay, you'll get a pick list back because we did, I think, rightly take the position that you should look at all the different ways your patient presented himself to you or the pharmacy or 5 other doctors. So if they have slight variations in the address or the first name, something like that, you'll get a pick list and you get to choose. You want them all, or you just want the ones you really know about. Then you hit this View Print Consolidated Report, and if the stars are all aligned, you'll get this, which will be your patient activity report. Hopefully, you'll be the only prescribing physician on there, and it'll be whatever you actually prescribed. Good luck with that. And if it's not, then you need to do whatever you need to do about somebody who's seen too many doctors, going to too many pharmacies, and getting too many drugs. So this is a very good indicator system that your patient may not be entirely truthful to you. It is not evidence. I like to stress it is not evidence. It is an indicator system. It's a pointer system. If an investigator is actually looking at anybody for a crime, they would simply use this data to go actually get the prescriptions at the pharmacy. The prescriptions constitute the evidence, not this. If ever this is used against you in court, make sure your attorney's smart enough to say, wait a minute, Your Honor, this is not evidence. Okay? except for administrative hearings, which is too bad because they have different rules and they probably can't use it against you. So, as you saw, the report brings back this data to you. In terms of outreach, I'm so desirous that we get more registrants that I do offer, if anybody ever has a function where you could have 20 or more individuals with completed application packages ready to hand in to me, that either I will go out personally or I'll get Joe or Joe to go out, and we can give you a little orientation on cures, but we can accept those in lieu of the notary. I need at least 20 to justify the travel costs, since I am defunded and don't really have any money. But with at least 20, we will come out and we will accept those and get your people processed. We've been very fortunate. When I came out about a year and 4 months ago, there were about 8,600 or so registrants, and now there's almost 12,800. So we're doing something at least. We're trying. And here's our contact. I'll leave that on for half a second for you, because there's really no one at those telephone lines to to answer those calls. So that information really doesn't help you. If you are somehow fortunate enough to have my direct phone number or my email, I will take your call. Like I said, I love spending those 3 hours a day doing nothing but that, but I will. And hopefully you do get a hold of me. Thank you.
Thank you. I didn't realize you were such a comedian. You hit it well. This is the last time I'm going to be up, so cures. And so I'm almost done. Cures. So do you know the cures? Yeah. I was actually involved with the Board of Pharmacy when we started this journey, and so part of it was our fault about the system not being great, but I wasn't the IT person. But we were definitely committed to this, and the reason that we wanted to do cures was because we felt that the triplicate program, after we investigated it some, Rafi Simonian in particular, for those of you who know him, actually went and saw what the program was at that time, and it wasn't really a monitoring program, it was a filing program. But it did scare the doctors because they thought they were being watched, and it did put limits on the use of these controlled substances, because not a lot of the doctors had these special security prescription blanks, and so they could use that to either not prescribe and tell their patients, but it also negatively impacted, which I was involved with, was our geriatric patients, our long-term care patients, hospice patients. So we did get some laws passed at that time that would help out those groups specifically, but we also wanted to develop a reasonable program, because we were aware that this is a problem and a concern when using controlled substances. So I just wanted, this is just the newest article that I saw before I left. In Los Angeles, the Los Angeles Times, they were talking about the fatal drug overdoses. You've been overloaded with that, so I'm not going to spend a lot of time on that. I just went through the history for the most part, but just to see, in 2004 was when the triplicate prescriptions were officially eliminated and were not effective and be used, and I didn't have the 2009, which was when practitioners could first access it. So we actually haven't had the ability to access it directly on the web for very long. The benefits of Cures were, it was an automated system, it's web access, all healthcare providers can access it, even though you have to go through Mike to do that, and he's working alone. But it did provide some better oversight and data as regards to the triplicate program, and it may assist in investigations and prosecutions, but that isn't really our main focus. It does have a lot of clinical uses, medication doses and the refill history you get. It can help you look at doctor shopping and pharmacy shopping especially. And then we actually did have it used when a doctor actually wrote a prescription for a patient. I mean, they're an employee, and then the employee took that and ran with it and was getting refills and doing all kinds of things. So the physician who was a prescriber did get that cures report and then did use that to show that he had actually done 8 refills that he hadn't actually done. So it has some good protective devices for that. This is a case that we actually did use cures for, and this was a 42-year-old male patient at the cancer center, and he had just had a recent diagnosis of lung cancer, had gone through into the ED with chest pain, did get this diagnosis, but he did have this little history of heroin addiction. So he comes into our pharmacy at UCSD because we're affiliated with the Morse Cancer Center, and he was on these medications. Gabapentin, 300 Q8, Ambien 5, which is really low dose for somebody who's been using a bunch of drugs. And then he is on this drug of Cadian, which is morphine sulfate. Now you can see he's getting 100 milligram capsules, and he's getting 15 twice a day. So 1,500 milligrams is what the prescription is for. Methadone 15 twice a day, and then oxycodone 30 milligrams as the PRN dose. I don't know why they're using different drugs, but we're not here to talk about that. The thing is that the pharmacy was prepared to not fill it. And so they had called the doctor, they had done their due diligence, and then they said, I'm not filling it. And I don't know how, I must have run past the office or something at the time they were talking to the manager to get the approval to not fill this. And so he called me, and knowing that I'm a pain advocate and was very involved with cures. And so I found out what the patient had been on. He had been on 2 grams. And then when I looked at it, it was like, well, the oncologist was prescribing it. The oncologist had said, yes, this is what I'm prescribing. He is an oncology patient. He does have a history. And with that history, I would expect he would need higher doses because he did have a history of heroin addiction and abuse. So I looked at it and I thought, well, they're increasing the dose by 1/3, but that's within a reasonable amount. It's pretty aggressive, but he was still having a lot of pain. So what I did was I ran a cures report. I confirmed that he was only getting his prescriptions filled at UCSD. He was only getting prescriptions that this one oncologist was writing, and it only started in November when he had the diagnosis. Prior to that, he doesn't have a history of prescription drug use or at least in the cure system. So we actually discussed it. The pharmacist said, well, I don't feel comfortable. He could kill himself. I said, well, he could have killed himself on the 2 grams a day with a little alcohol, so, I don't know if that's a good reason. But we walked through this, we talked through it, and eventually the manager also approved that we would fill this for the patient, because I said, if we're not going to fill it for our patient at the medical center, who's going to fill this prescription? So we did fill it, and that's the story of using cures for that. I'm going to skip through that. I'm going to skip through this, except for the part here that's practitioners. Those are prescribers. This is the same data, but I just split it out a little bit, that less than 9% of practitioners have access to cures. And I actually used the smaller number of C2 prescribers, so people who had actually DEAs. And then for pharmacists, it's 2458 or around there. That's around the 6.1%, so it's really pretty low. I really think pharmacies should be using it more. Not going to use that either. So I want to talk about the cures program with the remaining amount of time, the good, bad, and the ugly. You've already done a good job of that, so thank you. And again, he's only been working on the program for a year. But, the access and utilization is low, and that's what we have you here for, and we would like to get more input. And I know there's going to be a panel later with the boards where you can discuss it and ask your questions. Providers' access, it's somewhat difficult, and I think requiring the notary and all that stuff is problematic, because that's a big barrier for many people who work 12-hour days and et cetera. There is a backlog of people who have applied and are put on the cure system or given access. I'm not sure what else you do, as far as before you give them access, or you just confirm that their information is all in the process.
No, we do check on the board systems and validate that the licenses are theirs and valid, yeah. So, the problem for us is we're taking these applications over the mail, and a former life of mine where I dealt with less honest people, like private investigators and adversaries might, I used to do a lot of work with people who would wear vests with their motorcycle club emblems, and They like to mold people into state agencies to get data. So I'm just doing everything I can to make sure it's only a appropriate prescriber or dispenser that is applying to the program, and that I'm only letting those kind of people in, because this is very sensitive data from my point of view. We don't, I even go after, in fact, I keep a list, and I personally called all the doctors who inquired against Whitney Houston, upon her demise, reminded them that if you're not her personal physician, you shouldn't be asking about her. So we try to protect this data as best we can.
So there's other concerns. There's communication of concerns, and I hope the board will talk about that. We've already mentioned when you have a patient or you have a non-patient or a potential diverter or addict, what do we do with that information? There used to be there is still a checkbox that says, is this suspicious activity? But Mike says he took that out, but the checkbox is still there, but there isn't really any follow-up to do that. And we don't have any parameters, again, for when we would do that and why we would do that. Formerly, the Bureau of Narcotic Enforcement, that was folded at the end of last year, used to communicate, people to pharmacies by fax, and that was a very helpful program for us, at least in Southern California. That was stopped then, although the Prescription Drug Abuse Task Force is talking about maybe doing that again, so they can notify pharmacies when they have people who are doctor shopping, and so that they could be alert to at least evaluate them for the suspicious activity. You saw these screenshots before, but the reason that I wanted to show you this was, as a new user, when I started using it, I would put all the information in, I would get that checklist, and then I'd go down to see where it's red and it says no patient prescription transactions found for the selected patient period. That's like a surprise. And so I learned that you had to go back down to those buttons and say, generate the report and print the report. But if you're new and there's no instructions, that stopped me the first time, and I went to get help from the person who actually knew what they were doing. I mentioned these already. This is what the report, this is a report that I just pulled 10 days ago or so, and I haven't figured out what I want to do with it. It was an inpatient. They actually called and said, we have an inpatient here and we'd like to see what's going on with this patient with the cures. If you can see here, 106, that's the number of hits that this person has gotten. That means a lot of people. That's the highest I've seen. I don't know what the highest you've seen. Usually it's in the 20, 30 range.
Yeah, I've seen several hundred more.
You have? So that means there's enough people or places concerned that they have checked this report that many times. Again, I looked closer at the data. There was 86 prescriptions in this one-year time period that I ran the report. There was only 3 MDs, though, listed. So really a majority, like 95% of these prescriptions were written by one physician who is a rheumatologist. So you can see here the first one, I printed it out so you can see it. But there was a total of 8 pharmacies. So we're kind of in that borderline of, is this legit and what are we going to do with it? You can see that in February of 2012, there were only 2 MD prescribers involved through the time period. And this is what the patient was getting: amphetamine salt, which is a red flag because you need to look at if they're getting amphetamines and opioids, sleepers, OxyContin, and oxycodone, which is not, tremendously bad, but again, this is a rheumatologist, and I don't see what other treatments the patient's getting because they're not controlled substances. When I did look up February, up to February 15th, so I looked at February a year ago, this is what the patient was getting: Zolpidem, about the same. And you can see here I listed, it was a grocery chain pharmacy. Then they got Valium, diazepam, 10 milligrams on the 5th, this is just of this year, at a discount pharmacy. Then they got their OxyContin through their mail order, which they had been doing before. And then oxycodone was from a pharmacy chain. And then they got diazepam, 10 milligrams, number 60, from this pharmacy chain the same day as they got the oxycodone. But the problem was they had gotten the diazepam on the 5th, and then they got it on the 6th, 60s of both. And then they got Zolpidem at a big box chain. So I don't know if the pharmacies have been scrutinizing, talking to them, making them have to go to different pharmacies, but I would definitely be concerned if I was the chain number one and hadn't really checked the cures report. I don't know what to do with this. That wasn't the point. It was just to show you that you do get some data that gives you some good information when you're evaluating these patients. I think we would like the system upgraded. You have a lot of the upgrade information, don't you, in yours? Great.
Yeah, a little bit, yeah.
So I'm not going to beat this to death, but we definitely need to upgrade this system. I'm a big supporter of cures, as you can probably tell. I would like to see the Schedule 5s. We had the case about, the cough syrup with codeine and using gallons of that from Judy. And I would like that the prescribers who receive cures access with their DEA registration. I don't understand why they would necessarily be separate, because they're supposedly going through security and evaluation before they can get that. See, so these are just kind of pie in the sky. Health system licensee access, when I first started accessing it, it had a checkbox, or it had something about if you have 30 or more prescribers, you could get a facility, and you talked about that. But then when we checked into it, that system really didn't exist, because I had our IT people contact you. But I'd definitely like to move forward to see if we can do something like that, because then all of our providers wouldn't have to go down and get notarized, et cetera. And then what our doctors have asked for is online real-time access to the data, similar to the insurance that I talked about earlier. So they actually want something that would even possibly be proactive. So knowing that the patient got that Valium yesterday when the pharmacy was going to fill it, or even if the doctor was putting it in our system, that it would give them that feedback that it was already put into the system and they picked it up yesterday, or was filled yesterday at least. It's probably not going to tell them whether they got fixed up. And then we were looking at professional guidance, best practice. You've asked a lot of relevant questions. We have questions on cards that hopefully we can incorporate to develop this system. I mean, we have a big percentage of users, people who have access to the cure system, so I'm really happy about that. We would like your input so that we could upgrade this system. And again, if you're looking for guidelines, there's a pharmacist manual, there's a practitioner's manual from the DEA, although their focus is a lot more on legitimacy of the prescriptions rather than maybe the clinical evaluation and how to use a system like this to evaluate.
So like everybody today, I have too much to talk about and 15 minutes to do it in. So we'll try, you post it, yeah, perfect, yep, good, thank you. All right, so I've got the FIP at the end of my name there, so I hope I'm not taking that. I think, let's see, where are we at here? Let's see here. So the goals today, this kind of reminded me the picture of our Florida clinics, but the goals today is a little bit to learn how to use it, and I want to talk a little bit about what the literature says about prescription monitoring programs, and some in particular about cures. Dr. Fishman, our UCS Davis friends who were up here earlier, have done a very nice job in getting some stuff published. The second is, be an advocate, see if you can talk to your legislature, and we need this. I can't imagine practicing without it, and I hope that everybody somehow gets this done here. Let's see. So, what are our possible uses? And I won't go over this too much, but these first three are pretty obvious. We want to identify and prevent drug abuse and diversion. We want to support use of legitimate use. I know when this program first came out, and there were a number of my patients that I was very scared to run the first cures reports on, and it was very gratifying for most of them to see that I was the only one, or that those doses were there. They weren't getting other opioids from other people, and so that I do have patients who benefit from these medications, and I hope we don't take home that these are all evil. Second, outline the use and abuse and trends for information about public health initiatives. We want to do research. I'm at a university, but we always are trying to improve how we are treating our patients, and I think that's a big goal. Okay, And then last, and the thing that I want to talk about is that it's a great way to reconcile what the patient is taking and what you're taking, or what you're giving him. And when patients come into the hospital, we can find out what drug they are. Not all patients know hydromorphone from morphine, and they'll call it their morphine pill. They'll call it their OxyContin pill. They will call it their oxycodone pill. And these drugs are difficult. Physicians sometimes get confused about what is Cadian and what is Oromorphin and different things. And it's a very nice way to find out also what they're getting elsewhere in the community, and so that it can be a very positive tool for you to use. But really what it's not, this is only one data point, and it's not pathodemonic for addiction if there's something that's not there. These prescriptions sometimes don't get back, they're entered by humans, they're entered incorrectly, and then when the computer searches for it, it doesn't work. I have not had a lot of problems with that, but remember that, and that this is part of a comprehensive exam when you're trying to evaluate your patients. And these opioids, if nothing else, we learned the last 2 days, are very complex to prescribe, and we need to follow our patients very closely to make sure that they're benefiting and not having harm from this. The second thing is that a history of physical exam is always important. Using risk screening tools, imaging and lab results are important. Urine drug testing, all of these are one-point things, but using those to decide to use opioids when there's a diagnosis consistent with the need for opioids. And we had a lot of questions about what is that, and I don't know if anybody has a good answer, and that's why it's not limited, but you have to develop some kind of clinical experience and comfort and judgment when you see these patients and try and figure out how to use those. So I think that this is one more tool that has been very effective. So why aren't we using it? 11% have simply not applied. It's just one more password to remember. It's one more thing to do before you see a patient, and if it takes me 3 minutes to do that, now I have 6 minutes to see the patient, and it's a lot like this conference. You got more and more things to do. 9% reported a lack of computer. 30% forget the password. Every Tuesday is my big clinic at the university, and I think I reapply and get a new password every Thursday for whatever reason. And I always worry that Mr. Small is going to call me up and trying to see if I'm defrauding the system, or why is that password changing every week. But that's just one more password, and for some reason I can never remember it. And then 73% said that the time required to access the system is bad, and they had difficulty with the navigation, and so the problems with our cures is not unique. It's happening in the other 49 states that potentially have it, or 43 states that have it. And then last, 40% felt that it wouldn't change their prescription behavior, that if they looked at this data, it really wouldn't do it. I'm a doctor. I know if my patient's addicted or not addicted, and right there, and I'm confident that I'll figure out who's the dirtbag, and the little old lady in the wheelchair is a nice person, and she knows my mother, so she can't be a problem. So, so what happened? And I'm putting this in just, I think I was sitting there, I couldn't see everybody's slides, but I think we see it, so there it is, and to me, this second one's the most important button there is. But so you get to this one, and all you have to do is push here, and again, just put in the data, the date of birth. I just copy this right out of the electronic medical record, so you can do it pretty fast and drop them in there. I always get 12 months. In the ER, you may not need to get 12 months of data, but I always just default to the 12 months when I'm searching that. And then I always forget to get that. Check that I'm doing this for my clinical practice. I always get an error button like that, but that's okay. And so then you get here and you put the X's in and then generate the report, and then you got to push that consolidate report. And I'm glad that Darlene said that she had that problem. I had that problem. It was like, why can't I figure it? I know I prescribed this patient, and then it took a little bit of work, like any computer program. Oops, we're getting back to the war here too quickly. So what do you do when you look at these reports? And I don't want to go through examples of what this is, but there's some trends that I think can be helpful. When you go back one step and you find 20 addresses and the patient's moving around a lot, that's an indication that there's some economic hardship, or that the patient may have some problems, and that's one clue that I'm looking at when I see 20 different locations versus 1 or 2 locations. Some of the other things the real simple things that I begin with is how many doctors are on there. If I only see one doctor or I see one practice, that tells me the patient has established a good relationship with the physician that they're providing, and that physician hasn't had problems with him, that he's continuing to treat him, and either they've got him or her snowed, or they're a good patient, and that always is a bad sign when I see multiple physicians. The second time I'll look at, and I'll look at the quantities, and when I see a bunch of quantities of 10 and 30 and 15 and 20, that's somebody in the ER or in primary care who sees a problem with addiction and is recognizing it, but is just writing a quick prescription to get him out. And maybe I'm a little bit biased about that, but that's a clue that you may have a patient that has a problem. Obviously looking at dose is important, but also getting out and figuring out how many prescriptions that they've had in the last 30 days is real important. And when you see them and counting back and going, okay, that's about a month, there's about a month, and there's about a month, that's somebody that's coming in and is compliant and working. And I think that helps you a lot. The other one to look at is it's nice to see when the dentists do write those 30 prescriptions, and you can ask, well, why we're having all these problems with your teeth, and maybe it's a crystal meth problem, but you need to look at that, and so you can find out. And some of our patients don't know that they're getting an opioid, and that they're not violating a drug contract. That, I didn't realize that Vicodin was part of that. I've been on this morphine for a long time, and suddenly you'll see a urine screen, and it will be able to go back and validate it. And so there's a lot of information there, and you can spend a lot of time, but it doesn't take a lot of work to get some real important information that really helps you in making that decision. Should this patient remain on, or is a patient be taken off of opioids? So what's the literature saying about how does it impact our patients? This is a study out of Ohio, and we know that's one of 50 states that has a problem with opioids. But this was in the emergency room, and what they found was that they had patients receiving up to 128 opioid prescriptions from up to 40 clinicians and 20 pharmacies in a 12-month period for that ER. And they were looking mainly at behavior of the ER physicians, and after they were asked to say what they would prescribe, and then they were given access to their system, and they found 41% of them changed the prescription. And not all people are bad. 2/3 got less or none, but a third that they were legitimate concerns, and that the medicines that they changed what they were going to prescribe, and hopefully they changed it to be more effective and prevented them from needing emergent care. I think going to the emergency room with chronic pain kind of takes the word chronic out of it, but we don't. We're down in San Diego, kind of with the emergency rooms, talking about not refilling any opioids at all, or at least not OxyContin, or oxycodone. So, the second one is, how does this impact populations? The Department of Justice compared states with and without prescription monitoring programs, and concluded that programs that reduce the per capita supply of Schedule II, and that proactive programs were slightly better than passive programs. And a proactive program would notify a physician if they saw a patient that has some kind of aberrancy on their prescription, that they have higher doses, they have multiple early refills, that they're getting prescriptions on the same day, or having multiple pharmacies. And then they would send out a letter to do that, and some of the prescription monitoring programs are doing that. And there was a trend that it was better, but not necessarily. We have a passive program because it requires us to actively go in to search for the patient, and that's the difference. Another study in pain medicine reviewed admissions to poison centers, and these were kind of, quote, intentional exposures to Schedule II medicines. So these were abusers who were taking these drugs, and then they divided them out by states with and without prescription monitoring programs. And during that period from 2003 to 2009, states without programs had an 8% increase of exposures to poison control centers, and in states with the program, there was a 0.8% increase, so a tenfold increase there. And then it was cut in half about admissions for substance abuse disorders in states that had prescription monitoring programs. So, that's some pretty effective ones. Ooh. Let's see where we go. Okay, can I try and do that? Yeah, sorry. I'm just pushing it once. Right there. Okay, and so this is coming out of UC Davis, a study of our program in 2007, and I think that it was an attempt to find how many people were actually doctor shopping during this time period. And what they defined doctor shopping as a patient receiving a prescription for the same medication from 2 or more practitioners filled by 2 or more pharmacies within the 30-day period. And as we've already said, it excludes the VA, the military, prison facilities, out-of-state or international prescriptions for opioids. And then also, Cures does not tell us whether the patient is receiving that prescription legitimately or due to aberrance. The patient that's on chronic opioids and breaks his prescription and then gets a prescription from his orthopedist for the broken leg that night would pop up on this, but that may not be necessarily that the patient is doing it illegally. And so what did they find? It was very quick. About 8% in 2007 were doctor shopping using this criteria. Opioids, just like all the slides we've seen, were the highest. The benzodiazepines were second. Stimulants were a little bit lower. And the risk of doctor shopping was increased by 2 times if they had two of those categories. So if they had an opioid and a benzodiazepine, an opioid and a stimulant, or a benzo and a stimulant, they increased. If they had all 3, I guess we learned that was the Holy Trinity, or the Trinity at yesterday's talk, but a 13-fold increase if opioids were both there and stimulants. And if they were receiving those simultaneously, meaning that they were getting them all from the same location, it showed the greatest incidence of problems. Okay, and so interestingly, and kind of contrary to what all the other slides showed, that hydrocodone was not associated with doctor shopping. I hope that's a one data point, and I don't want to discourage people from doing it, but a lot of this information is important to know. The hydromorphone and the fentanyl lozenges were the highest. It was kind of before all the instant release fentanyls were released, but those are high risk. Younger age was associated with opioids and benzos, olders with stimulants and anorexics. And interestingly, the duration and amount was not clinically or was clinically inconsequential, meaning that if somebody was on higher doses, if somebody had been receiving it during that whole 12-month period, they did not pop up as having problems, and that it really warrants heightened vigilance. And I wanted to say that this Cures program is really designed to increase that vigilance and give you one more positive tool. I'll try and go there. There's some concern about this program, and it's not all positive, that there might be a substitution effect where physicians don't want to, will say that the Schedule II will pop out and the Schedule III will not. We monitor Schedule III, so I'm not sure in California that makes a difference. Also, if hydrocodone gets scheduled as a Schedule II, that will remove it. And then the other concern that more drug abusers will shift to illicit drugs. The talks this morning and yesterday show that the movement is more based on economics and not physicians being afraid that we're going to be identified for prescribing these medications. There is some evidence that Schedule II drugs such as oxycodone was lower in states with programs, but the same states had higher hydrocodone uses, which is a Schedule II. So there is some evidence that may be occurring, and whether it's relevant or not. And we can see that also with the oxycodone now that it's formulated differently, that people are moving to just the short-acting versus the long-acting drug. Okay, and that last one. And just real quickly, these are two quick review articles about prescription monitoring programs that give a little bit of discussion about what is in place in other states, and this Health Affairs very clearly lists what other options we have to do that. And how am I doing for time? So I guess I went through that pretty quick. Good. You're going to end early? I'm sorry. Thank you.
And you might be able to catch some of these individuals at our next break. Our next group coming up, if I can have the panelists come forward, please. Our next panel is composed of enforcement, investigation, and prosecution members. Dr. Winder is our panel moderator and will be taking a number of questions from the audience after we have some presentations from our panelists.
Good afternoon. This is a panel on enforcement and its prosecution, not persecution, if there was any question about it. I'd like to start the questioning off by asking people from the pharmacy board, how does the pharmacy board discipline process work?
Would you like us to introduce ourselves first, or?
I apologize. I thought at this point everybody had been introduced. If you have not been introduced, please introduce yourself to the group.
Hi, my name is Lynn Dombrowski. I'm a Deputy Attorney General in the Health Quality Enforcement Section of the Office of the Attorney General. I'm based in San Francisco, and I'm one of approximately 45 attorneys in the state of California that work with the medical board in handling disciplinary administrative actions against doctors. We also work with other health licensing boards, and I've been in this practice for over 18 years.
I'm Joshua Room. I'm a supervising deputy attorney general, also in the San Francisco section, San Francisco office. I work in the licensing section. By sort of historical coincidence, there's a subdivision in our office between the attorneys that prosecute cases for the medical board and some other affiliated health professionals, and those in the licensing section who basically do all other kinds of licenses, including pharmacy, nurses, chiropractors, contractors, auto repair. So I have personally been the liaison to the Board of Pharmacy for about 10 years now, and so my particular expertise is in cases involving pharmacies and pharmacists.
Hi, I'm Ruth Morenz. I'm with the City and County of San Francisco, and I'm the manager of the Special Investigations Unit, for those of you who weren't here yesterday.
I'm Laura Myers. I'm an assistant district attorney in San Francisco. I've been a DA for 27 years. I'm assigned to the white collar division, and I work in prosecuting workers' compensation insurance fraud.
Joe Rennes, I'm with the Drug Enforcement Administration.
My name is Renee Threadgill, and I'm the chief of the enforcement program for the Medical Board of California.
I'm Judy Nurse, and I'm a supervising inspector with the Board of Pharmacy.
Okay, I apologize. I don't want to get in trouble with the Attorney General's office. At least it's not the state tax board, so I guess it's
What's your license
it's
number
preferable.
again, Dr. Winder?
I don't have I have a driver's license, I think.
So anyway, I'm sorry, you asked a question about the pharmacy board enforcement process. And I mean, Judy can probably do this as well as I can, but I'll just give the brief primer on it, which is the formal enforcement process relates to anytime you're going to seek license discipline, that's an accusation that's filed, and that follows an investigation process that happens separately from my office. It happens are entirely internal to the Board of Pharmacy. Once that case is fully investigated, then it's forwarded to our office for purposes of pleading and filing. Now that's the sort of formal disciplinary process. That's for the most egregious cases. There are lots of interim administrative sanctions and smaller sanctions that the board can levy, citations and fines and letters of admonishment and things of that nature, that are also preceded by that same investigative process. Now, sometimes that investigative process involves interviewing of the respondent, what we call the respondent, the person who's the subject of the investigation. Sometimes it doesn't. Sometimes it involves sort of third-party investigations, interviewing other people about that person. If that person's the subject of an investigation, they may not know until such time as a pleading is filed against them. But more often than not, that person is aware of the investigation once it's progressed to a point at which it's been substantiated. We don't always make people aware of every complaint that's made against them, because unsubstantiated complaints are not worth, you don't want to know about every unsubstantiated complaint that's been made against you. We only make you aware of that complaint at such time as it may have been substantiated to at least to a minimal degree. I don't know if there's anything you want to add to that, Judy. Okay. Judy's going to try to avoid speaking at all points.
Let me ask you this. What type of cases come to the pharmacy board?
Well, I think as Judy alluded to in her separate talk, there's been a kind of a sea change in the last 3 to 5 years in the kinds of cases, and I think it's a reflection of the depression in the economy, that more and more inventive ways to make additional income are being thrust upon or are voluntarily sought out by members of the pharmacy community. And so whereas, for instance, corresponding responsibility cases were a very small proportion of our overall caseload a few years ago, they're becoming a larger and larger proportion of our cases. We also have lots of other schemes that you might not have imagined years ago of pharmacies, essentially repackaging returned and already dispensed drugs for purposes of placing them back into the distribution chain. We've discovered lots of sort of informal or formal for their purposes, but illegal for our purposes, backroom packing houses in pharmacies where you go into secret rooms and discover packing houses. So all kinds of things that you never would have imagined years ago. And as Judy alluded to as well, there's a lot more influence, I think, in recent years of organized or disorganized criminal enterprises infiltrating into pharmacies. And a large part of that these days is by the use of the pharmacy tech license category, where individuals either already are members of criminal organizations when they get their licensure and come into form pharmacies, or they are pressured either by members of their neighborhood or people that they run into to become conduits for these criminal enterprises, and so that diversion on a scale unheard of a few years ago is becoming more and more commonplace, of drugs just disappearing in huge quantities. And as Judy alluded to, the inventory control for that being difficult, in the sense that these people are inputting false data into the inventory control systems to cover up the large-scale theft that's going on. I'm sure Judy could identify additional types of cases that, are sort of the meat and potatoes of what they investigate. I mean, this is in addition to all of the sort of normal inspection and regulatory compliance stuff that the board does as its routine business and its response to complaints. What I'm talking about here is really the kind of fraud and diversion cases that would be relevant to a controlled substance discussion that we're talking about here. But that's, even if you look at that work, it's still a small fraction of the work that the board does overall.
Anybody else like to comment on that? No?
As I said, Judy won't talk as long as I'm talking.
Is there a difference between the mom and pop pharmacy versus the big chains as far as how they handle their inventory or problems with the pharmacy board?
There is a difference. Chain stores have usually very defined systems. They usually have data mining systems. Because they're part of a retail operation, they're always looking for inventory shrinkage throughout the store. So these types of issues are much more common to them. They tend to have loss prevention departments, just better organized. When you go into a mom and pop or an individually owned store, you don't know what you're walking into as a regulator. And so you may have a very well organized, very well run pharmacy, and you may find the opposite. You may have record keeping that's very, very good, security that's very good. On the other hand, you may have people who have very trusted employees that, you tend to get very close to your employees where there are just a few of you in a confined space over, 10 or 15 years. And so, in this environment, it's changed, and you have to watch very closely. And so we can have some very large losses out of those small pharmacies, 250,000 Vicodin. So I'm not, so yes, there's some differences.
And one thing I would also say is just, I think as margins in pharmacy have dropped significantly over the last decades, that has hit independent pharmacies particularly hard, and particularly in the most recent years of recession, such that I think when these schemes are floated to pharmacies of ways to make additional money, it tends to be the independent pharmacies that are the most likely to be victimized by those schemes and most likely to end up getting a visit from us because they are the purveyors of illegal activity that they may or may not have realized that they were being drawn into.
In addition to what we're talking about, we also still have internet problems. With Ryan Haight Act, we have much reduced controlled substance internet issues, but we still have internet prescription issues, and we have billing fraud. Like Josh said, when the economy is bad, the billing fraud's going to go up. People are struggling to stay in business.
When does the problem cross the line from a state problem to involve the DEA?
You want us to answer, Joe, or you want to answer?
I haven't heard anything from him. I thought he was sleeping down there.
I just want to start by saying it's not a state problem or a DEA problem. It's all of our problem. I mean, a violation is a violation. What a lot of people don't understand is we work very closely with each other. I think Jenny could tell you that we're DEA is very close with National Association of Boards of Pharmacy, and therefore very close with the pharmacy boards and the medical boards as well. And we sometimes look to the medical and pharmacy boards and we say, hey, what do you think about this? Where do you think we should go with this? It's a collaborative effort. Don't think for a second it's us against them, because that's not the way it works. We work hand in hand, because when it comes right down to it, if I have to show whether somebody's operating outside the usual course of professional practice, I look to the boards, and the boards provide guidance for that.
Yeah, I mean, I think the only segmentation we do in terms of investigation is if it involves controlled substances, we bring in DEA immediately. If it doesn't involve controlled substances, then there's less ability to bring DEA in. But there's a lot of joint investigation that goes on, and a lot of cooperation. So.
Well, why don't we go to the medical board? Renee, do you want to talk about the medical board disciplinary process?
Okay, or I can have Lynn Dombrowski, who certainly
Lynn can do it too.
can chime in.
I have nothing against the AG's office.
Why don't you go ahead, Lynn?
Well, with the medical board's cases, before they reach the Attorney General's office, typically a complaint has come in at the Central Complaint Unit in Sacramento, and there are certain things that are done. They are reviewed, records are requested, a review is done by a licensed physician in that specialty, and it's decided whether there's any merit at all to the complaint. If there is, it's forwarded on to the district investigation office for investigation. An investigation takes place. Usually the complainant or the patient is interviewed, records are obtained, the physician is given an opportunity to be interviewed about the matter. At that point, it is sent for an expert review. The medical board has experts in all the areas. In pain management cases, usually 2 physicians look at that. After they review it and their expert opinion is that there has been departures from the standards of care and practice, then it gets to the Attorney General's office. And at that time, we look at the case, we assess the evidence, we assess whether what the expert opinions are saying is based on evidence that we can present in court. The administrative hearing requires that we produce our evidence by clear and convincing evidence, which is a very high burden of proof. And we proceed from there and take an administrative action. The administrative action is, or administrative hearing, after it's conducted, the judge makes a proposed decision, and it goes to the medical board panel, and they determine whether they are going to adopt the findings and the decision that's proposed by the administrative law judge, or whether they're going to non-adopt it and make a decision on their own. Once that happens and a decision is taken, the doctor has an opportunity to appeal the decision in Superior Court. It goes to Civil Superior Court by a writ of mandamus, and at that time the Superior Court judge looks at the entire administrative record and is able to make a decision de novo, meaning a new decision on looking at all of the evidence, but is limited. They have to determine whether the medical board has abused their discretion, or whether they have, whether the findings that they have declared as factual and legal conclusions are not supported by the facts.
What advice would you give to the group of physicians in the room if you get that letter from the medical board that says a complaint has been filed against you? This usually puts tremendous fear in the hearts of every physician who gets this letter, and they always imagine the worst. What should they do, and how should they take it?
I would say cooperate.
Or else?
Be forthright and provide any information that you think the board needs to have in order to understand why you did what you did, if you did what you did.
Right. I mean, you have to understand we are not out to persecute doctors.
Right.
There are enough bad doctors out there to pursue that. If somebody has made an honest mistake or has recognized a problem, the medical board is not going to pursue that action. We are looking at physicians who are not taking responsibility or accountability for their actions. In the pain management area, if you have not followed the guidelines, if you have not done a physical examination and documented it in your records, or you have not conducted periodic review, done random urine testing, established that they have some type of chronic pain, referred them for other consultations. If you have not followed those guidelines, you could have some problems with the medical board, but otherwise you're going to be in a better situation.
I wonder if both on behalf of the medical board as well as the pharmacy board, you could talk about a case and how that was pursued and how what was the end result. Either medical board or pharmacy board or both.
All right, I'll go first, although you're probably tired of hearing me talk. Most recently, last year, I had a major pain management case against a self-professed pain specialist. The trial we conducted lasted 3 weeks. It involved 11 separate patient cases. 3 of those involved patients who had died. At least 2 could be attributable to the overdose of the pain medications, prescription pain medications that were taken. The case ended up resulting in the revocation of the doctor's license. Like I said, in that case, clearly the guidelines had not been followed. The quantities were staggering as to the amount of controlled substances that had been prescribed. I mean, we're talking about gallons of promethazine cough syrup in addition to 600 OxyContin 80 milligram in addition to Valium and Soma all at once on a monthly basis for these patients who are definitely paying cash to the doctor and having Medi-Cal or Medicare pay for the prescriptions. In that case, it came to the medical board mainly from pharmacists. At least 4 or 5 different pharmacists in the Bay Area had registered complaints with the medical board. After they had talked to the doctor and not gotten sufficient response, they had questioned the quantities and the types of drugs that were being prescribed, saying that they had only seen those for hospice patients, and yet these patients were walking in and out of the pharmacy. And also, at least one pharmacist had seen an exchange in a parking lot of the drugs taking place. So really, the pharmacists were the first line of people to notify the medical board that there had been a problem, and the investigation took place from there.
One question before you go. When does a civil case become a criminal case? And did this become a criminal case?
It did not, well, I think it's been forwarded, and I think there may be other issues pending regarding that case that I don't have access to that information.
Would you define how, I mean, there are certain physicians who, it was a very famous case we're all aware of a manslaughter case. How do you go from a civil to a criminal case? What does the law say in California?
It usually starts with the criminal.
With the criminal?
Yes, because their burden is higher. The burden of proof is higher in that case. So if it's clear that you have enough to refer it to a DA, generally we would refer it to the DA first, and if they accept it, the administrative case would trail. In those instances, we would be seeking either a PC-23 to take the doctor out of practice right away, or an ISO. I wanted to add something to what Lynn was saying about the case that she had. One of the things she isn't saying is that how dangerous the licensee was who we were seeking the action against, and the hordes of drug dealers that were in the court threatening the prosecutors, the investigators, because, you know, clearly their livelihood is contingent upon the doctor cooperating and prescribing the drugs. So they were quite upset and actually made threats to the investigator, and there were some drive-bys that they weren't shooting, but they were surveilling the homes of some of the staff that were working on that case. I just want to point that out because this is not something that we take lightly. Can be, in this particular area of our job, can be very dangerous.
So rather than talk about some of my more egregious cases, which I certainly could do, I think it might be a little bit more helpful to talk about some of those cases that are a little closer to what people in this audience may have experienced. At least hopefully you're not in the more egregious category. One particular case comes to mind of a longtime pharmacist who'd been practicing for 40 years, who had run his own pharmacies over the years, but at this point in his career was essentially doing a favor to another set of owners who owned a few small pharmacies, and was running that pharmacy for them. And either because the practice had sort of passed him by, or he just didn't realize that things had changed over the last several years, or because it wasn't his own pharmacy, he wasn't as attentive. The numbers of controlled substances and the quick upticks in controlled substance treatments that he was dispensing, it became clear that he just was not clinically attentive to the patients to whom he was dispensing. And he over the years had developed his own ways of sort of analyzing patients. He had various tools that he said he was applying. He had very poor record keeping, so it was hard to tell. But this is the kind of person that, at least in myself, engenders a certain amount of sympathy, because clearly he's dedicated a huge amount of his life to this profession. He clearly, really cared about his profession. He was incredibly embarrassed, and yet he'd had 2 patients die on him. Patients who, were clearly addicts and were self-destructive, and, there's only a certain amount that he can restrain that, but he was the person essentially handing out these drugs, and one of the prescribers was actually the prescriber that Lynn just described. This is an individual who was able to keep his license under strict terms from the board. But I mention him because I do feel like in my regular practice, I encounter a lot of people who are at that same stage in their career as pharmacists as this individual was, maybe 20, 25, 30 years in. Things are completely different now than they were 15, 20 years ago in terms of the number of addicts coming into your pharmacy, the people who are coming in presenting prescriptions in your pharmacy. He didn't really it never had occurred to him that van loads of patients would be brought in all at the same time to fill prescriptions all at the same time. It had never occurred to him that this prescriber would be completely abdicating his responsibility as a prescriber to think about his patient's best interests. And so he made some cursory communications with the prescriber, but he made no effort to either interview the patient or really even think about saying no to the prescriber when these additional prescriptions were coming in. So I think he is the person in whom I see the most opportunity for education and growth of people like him in the profession. The other kinds of cases I want to talk about just real briefly are, as I mentioned earlier, we have an increasing number of pharmacy technicians that are either members of organized gangs or are intimidated into diversion activity by organized crime or by gang activity. And I've had several cases recently against individuals who, as they tell it, I don't know what the real story is, but as they tell it, they were essentially coerced into diversion activities by threats against themselves or their families based on where they live, and that the pharmacy technician is a sort of a profession that tends to be an upwardly mobile profession. People from poorer neighborhoods, sometimes this is their way of getting into the middle class. So we have lots of people who are pharmacy technicians who may come from less affluent backgrounds and may be exposed in their own neighborhoods to the kinds of gang activity or organized crime activity that the people who are supervising them, the pharmacists or other professionals, may not fully appreciate or fully understand the pressures that person is under. So I've had several cases recently where pharmacy technicians are essentially acting as conduits to organized crime or gang distributors.
We've talked a lot about addicted patients. What about the addicted physician or the addicted pharmacist? How do we deal with that?
I actually, and I think Judy had a slide about this, although I don't know if she had time to really focus on it during her slides, but I actually think that the addicted physician or addicted pharmacist is a whole separate discussion from what we're talking about here today. I don't really feel like persons who are feeding their own addictions are even on the same scale of problem as what we're talking about in terms of either drug-seeking behavior by addicts or diversionary behavior by either individuals or large groups of people. The scale of what a self-using pharmacist or physician typically consumes is nothing approaching the hundreds of thousands of dosage units that are flowing out the backside of a pharmacy based on. So yes, there are means to address those impaired pharmacists, but there are also, the Board of Pharmacy passed a few years ago a statute requiring that pharmacies have systems in place to both detect and report impairment, and I have to say that's working pretty well, especially among the chains. I mean, the chains are very vigilant now about impairment among their licensed staff, and so we get a lot of self-reporting of that, or other reporting, but reporting by the chains. So I don't think that's in the same category of discussion as diversion or drug seeking by addicts.
I feel differently because I've seen a lot of malpractice cases of addicted physicians who killed multiple patients secondary to their addiction. And I think that part of our job is public protection, both protecting the public as well as protecting the profession and trying to prevent these things. So I think that, again, physicians and pharmacists have very easy access. Are we actually capturing anywhere near the number that are likely to be addicted? Every time I hear the statistics and we try and figure out how many are in diversion programs, it's a minuscule amount.
I think from our perspective, and I hope what you're saying is not an omen as to what's going to happen to us in the very near future. We tend to find that technicians will both self-use and steal. From the most part, our experience with pharmacists is the vast majority of pharmacists will steal for self-use and will not steal and sell, or will not sell large quantities. We deal with the self-using pharmacist or technician in, as Josh said, a totally different way then we investigate this type of diversion case that we're talking about. We have a group of investigators that are totally dedicated to investigating those cases and dealing with those individuals as long as they are our licensees, whether they're placed in a recovery program, they're on probation with our board, or whether they're eventually revoked and no longer pharmacists. But as long as they are with us, we have a very separate way that we deal with that.
And I didn't mean to imply that self-use is not obviously a serious problem or that it shouldn't be addressed, but I do think that there's a difference in scale, at least within the pharmacy
Yes.
community. I can't speak to impaired physicians, but that those cases are still as rare now as they were 10 years ago, whereas the cases of large-scale diversion and large-scale addictive drug-seeking behavior have skyrocketed and exponentially increased based on everything that we've been saying for the last 2 days.
I think the increase in thefts that we see, and we talk about, at least I talk about skyrocketing thefts, I believe that's an increase in theft for resale versus an increase in self-use. I'm sincerely hoping.
I don't know, Renee, with the medical board, my experience has been that the numbers of prosecutions or cases we get regarding impaired physicians who either have alcohol or substance abuse problems is probably about the same over the years. It's not changed that much, but the pain management
It may be slightly higher. Yes.
But those are taken care of fairly quickly once we become aware of the problem. Certainly those physicians, it's easier to get them suspended immediately if you find that they're a danger to their patient population. But pain management cases and excessive prescribing cases have been on the increase in the last 5 years or so.
How can we be proactive? I mean, obviously, when something comes to your attention, you deal with it. But what can the pharmacy board and the medical board and the DEA, for that matter, do to be proactive in all of this?
At the risk of sounding like a cliche, education. I think that the more well-informed the licensees are about the issue, and the more collaboration to come up with ways in which to effectively reduce this problem, get control, fixing cures, all of those things are going to have an impact on reducing the magnitude of this problem.
And let me say something in support of the medical board and the work they do. A lot of what I do is education, and I talked to a lot of the physicians during the break yesterday and today, and people are desperate for education and information. And one of the things I do to educate myself, whenever there's been a case that they've brought that shows up on the medical board against a licensee, I go read them. And it is a guide to best practices for what physicians should be doing. And you read a lot of the regulations, and they're cumbersome and they're boring, but when you're going through details of what's gone wrong with somebody's practice, and they're carefully laying out what should have happened with those physicians, it's a really good guide to best practices. And I strongly recommend reading them. They do a great job when they're doing their work.
I'm going to go around the room and let you ask some questions so you don't have to stand here for an hour to do it. And I'll start on the left and go to the right. Introduce yourself.
My name's Alan Gruber. I'm a pain management physician, anesthesiologist in Santa Rosa. There's been a trend among pharmacies, especially big box pharmacies, big chain stores in the past year or more, where my patients in an increasingly routine frequency are calling up saying that they went to their designated pharmacy with their usual prescription for, say, 120 oxycodone, and we're told there were only 60 pills available, and they accept a partial fill. And according to the regulations, that puts me on the hook for rewriting a second prescription in order to fill the balance. In the meantime, the pharmacy has a prescription on hand that they filled, who's to guarantee that they haven't diverted the other half of the prescription? And they've got a paper trail in the form of my prescription justifying, that, the half could go to the patient, half can be diverted. So that's a concern. Now, I've been told by at least one pharmacist that a number of the big box stores aren't stocking essential medicines on site. Some of the pharmacists have told my patients, well, we have to order your medicines from a regional pharmacy. Now, for 25 years, I've had all my patients on a strict, every month you see me, come hell or high water, and you will get your prescription within a 48-hour period of when you're going to run out. So they go to the pharmacy, and the pharmacy says, well, Mrs. Jones, we can't get your fentanyl patches for 3 days, and she's going to be out that day. And I disagree with one of the panelists earlier saying that detox is no big thing. People don't die from detox. Well, mostly they don't die from waterboarding either. So what's torture and what's not? And should we allow people to go through that?
Your question is what?
The question is, what is going on with the pharmacies that they are allowed not to stock enough medications, and how do you track down whether or not there's diversion happening when these partial fills are handed out?
Well, those are two very separate questions. I'll try to address them separately. The first is that there is no legal requirement that pharmacies stock any particular quantity or even that they stock any particular drugs. So pharmacies can make those decisions. Particularly in this stretched economic time, pharmacies are moving much more toward just-in-time inventory where they only have as much as they think they're going to need for that day, and they try not to keep any more on hand than they think they need. That may or may not be a decision that you agree with. It may not be a decision I agree with, but it's not my particular choice to make for the pharmacy as to how they choose to, unless it interferes with patient care. There are requirements that they have to, fill a legitimately issued prescription as long as they don't have some, judgment-based reason for interfering with it. But that's separate from the question of if they have the drug in stock or not. So the second question of whether that partial fill may be leading to diversion, we have no evidence that that's happening. I've not heard of any, I don't know, Judy might be able to comment on it, but I've not heard of any case or any complaint or any evidence suggesting that partial fill by pharmacies is either an anecdotal or a systematic way of diverting drugs to other uses.
Any other comments from the panel?
There's lots of people waiting.
Wait, please come to the mic, and then we go to the back and up.
Hi, folks. I'm Steve Meister. I'm a criminal defense attorney in Los Angeles. I think in my observation, there's a big gap between what I'm seeing at the district level and the message that the medical board is saying today about how people should be candid and cooperate. I agree that they should. But my experience at the district level, in case you're not aware, has been that we're not told when a client of mine is subpoenaed to the medical board for a senior investigator and an AG to talk to them. It may or may not be under oath. That's up to them at the meeting. We're not told why we're there. We're not told anything about the subject of the investigation. And my concern is it gets difficult to cooperate when we don't know whether we're walking into a trap. Are you aware of this dynamic, and would you suggest anything about how district investigators might be a little more candid with the subject of the investigation so that we can offer the information that they need to hear?
I would expect you as an attorney to seek the what you're entitled to prior to that interview, which is the 800C information, which would provide a summary of the complaint. So if you have...
We have that.
All right, if you have that, I suspect what you want is more detail about the complaint, which might interfere with the remaining investigation. So I leave that to the investigators and the attorneys who are working on the case, their strategy in obtaining the evidence that they think they need in order to proceed. But you do have the subject matter available to you by way of that 800C. You're not really moving in there blind.
Again, I will respectfully disagree. I appreciate the answer. Thank you.
Back.
My name is Dieter Steinmetz. I'm a pharmacist, and I want to bring up the question again as far as there seems to be a fear as far as pharmacists are concerned when we see prescriptions that are for large numbers of narcotics that we don't have the tools to evaluate, is this prescription being written for a legitimate medical purpose? I think the same to a certain extent holds true for doctors. So I would again like to propose maybe some guidelines that the medical board and the pharmacy board put together that would allow doctors to follow stepwise approach to prescribing and pharmacists to have a stepwise approach to dispensing that allows us to have that confidence that when we're taking care of a patient that needs our help, that we're able to take care of them. In the long run, it will also help prevent the diversion and the fraud from happening, because if you're following the guidelines, it's very easy to identify when something is being done outside of the guidelines. As much as I don't like overall guidelines in medical practice, for narcotics it seems that this might be something to seriously consider. I'd like the panel's opinion on that. Thank you.
I'm happy to speak unless you want to go first.
There are guidelines for prescribing controlled substances for pain. They're on the medical board's website. Certainly, as I've talked with licensed physicians in the state, they are representative of what the standards of care and practice are in the state regarding that prescribing. They're general. They are not so specific to tie a physician down to a particular drug or amount, but certainly it sets the groundwork for that.
And the thing I would add to that is that I don't think you have to remember that the state agencies you're talking about are primarily enforcement and regulatory boards that are not themselves the agencies that are out there setting these professional standards. So what you're most likely going to get are the things that are indicators of trouble, the things you shouldn't be doing. You're much less likely to get anything that says within these guidelines this is safe behavior. That's just not the role of these regulatory bodies to tell you or to provide guidelines on what is safe prescribing or dispensing. That's not our role. What we can tell you, or at least what the pharmacy board can tell you, are the kinds of things that, for instance, were identified in Dr. Fujimoto's slides and that Dr. Nurse has also talked about, red flags that ought to put you on a duty of additional inquiry. If the prescriber and the patient are geographically distant from one another, if the prescriber is out of state, if the prescriber consistently prescribes only the same 3 drugs or 4 drugs, if the patients arrive in vans, if the patients are paying in cash, all these kinds of things are and will be after this conference essentially guidelines as to behaviors that should put you on notice that additional inquiry and documentation is required.
Any other comments? Kurt?
Hello, my name is Miran Choi. I'm a psychiatrist. Before I leave today, I'd like to be as clear as possible about my options or obligations under HIPAA if I discover that a mutual patient, say for example, is receiving multiple prescriptions for hydrocodone, say from an oral surgeon. What should I do? And secondly, could you speak to whether there are any legal cases pending regarding stimulant diversion?
I don't know if anybody else, Joe, do you want to talk about HIPAA or do you want me to do it?
Please. HIPAA confuses me.
I mean, you are the federal guy up here, Joe. Quit ducking. HIPAA is obviously confusing. What I will say is that, and I'm not an expert on federal law, but what I will say is that HIPAA, to my knowledge, places no restriction on your ability as a person for diagnosis or treatment of your patient to communicate with other health providers who are also providing diagnosis or treatment to that patient. So you are at least at liberty to communicate with that other prescriber to determine whether, between the two of you, you detect a problem. You are also at liberty to communicate with law enforcement officials about suspected criminal activity. And criminal activity could include doctor shopping, because it is unlawful for a person to be inducing you to write illegitimate prescriptions. So I want to make sure that I'm careful here. I don't want you to be the police. I don't want you to be feeling like you have to, interdict these kinds of individuals. But if you have a suspicion of criminal behavior, you ought to feel that you can report that information.
Also, I believe that if it's a chronic pain patient for whom you're prescribing opioids or sedatives or whatever it is, I believe that agreement includes, or I've seen forms that include the authorization or the understanding that the patient understands the physician will be consulting with other practitioners at their option on the patient's care and treatment.
Yeah. What was the question about stimulants?
If there's any investigations of
Stimulants.
Well, I can't comment on any ongoing investigations, but I suppose it's a question of whether the board is looking into the practice of excessive prescribing of stimulants. Is that the question? I don't know. Renee?
Again, we are in the process of investigating a variety of cases that involve overprescribing or of drugs. Which ones, it's difficult to say now, but keep your eye on the newsletter, and I'm sure that you'll see one that'll strike a chord.
Renee, if she were to report this oral surgeon, would she report it to the medical board, or would she have to call the dental board?
Well, the oral surgeons aren't investigated by us. That's the dental board. But if it's a doctor that you see that is prescribing also to that patient that you want to make us aware of, we would appreciate the information.
Kurt? Okay. We'll go to the back.
My name is Armand Markarian. I'm an attorney practicing in Southern California, and about 25 to 30% of my workload, I represent pharmacists, physicians, and other healthcare providers. The question I have is based on enforcement and prosecution. What I see in the past 2 to 3 years is a significant increase in the number of corresponding responsibility cases. 10 years ago, we barely saw that. But what I don't see is wholesalers being charged with an offense. You know, the corresponding responsibility the statute is the 11153 of the Health and Safety Code, and a sister statute, 11153.5, essentially says that a wholesaler shall not furnish controlled substances that are not for legitimate medical purposes. And my question to the Deputy Attorney General is that, of course, they have the discretion to charge or not, but why is it that we're not seeing as much activity with respect to the wholesalers? And one case in particular, a few years ago, when the wholesaler was, in fact, the Board of Pharmacy, I believe it was, that they went after the wholesaler, and they were hit with a cite and fine, and the citation was only $2,250, where this very small pharmacy out in the suburbs of Sacramento, there was over 400,000 tablets of hydrocodone, where the pharmacist licenses, the board wanted to revoke them. And that's just one example.
I guess that's for me. I have to confess a sort of lack of ability to answer this question, because I'm not aware of a case that it was brought to my attention in which it would have been possible to charge a wholesaler with a 11153.5 violation. That doesn't mean that what you're saying is untrue. I don't know that case, about the case you're talking about. And I'm not aware of, I think you have to be aware, though, that it's going to be a very different case. The fact that a individual pharmacy or pharmacist failed to exercise corresponding responsibility with regard to an individual patient does not mean that there would be a corollary case against the wholesaler that supplied the controlled substances to that pharmacy for any number of reasons, but including that even within what would seem a reasonable allotment of controlled substances to a particular pharmacy by a wholesaler, it's quite possible for an individual pharmacy or pharmacist to completely abdicate the responsibility to make sure that all of those drugs are not going to one patient or a subset of patients. So I don't think there's any equivalence that necessarily should be drawn between a pharmacy that's hit under, or a pharmacist that's hit under 11153 and a wholesaler hit under 115.3.5. I believe, and Judy should correct me if I'm wrong, but I believe, as the representative from H.D. Smith pointed out earlier, that the wholesalers that we deal with typically actually have pretty proactive systems in place to detect unusual buying patterns by pharmacies, and quite often are the ones that report to the board when pharmacies are exhibiting unusual behaviors. Now, that doesn't mean that they're all perfect or that they aren't subject to the same temptations that might strike a pharmacy, but I'm not aware of wholesaler activity of the type you're describing that would warrant that kind of prosecution. I don't know if Judy has anything to add to that.
I would just comment, and I'm sure Mr. Renazizi has comments. Just briefly, we do investigate pharmacies. I'm in charge of the fraud diversion, and we have a number of those investigations ongoing currently, and I'm aware of a number of them in the past. The outcome, I'm the investigator. I don't determine the outcome. But I'm telling you that those investigations do occur. Of wholesalers. Oh, I'm so sorry. Of wholesalers. In response to, lots of times in response to to a pharmacy case that we have conducted, and we also have conducted independent investigations. Joshua mentioned that the larger wholesalers in the state of California tend to be, at this time, very proactive, and all tend to have pretty good systems in place, and I would attribute that to the DEA and their activities with a number of those entities, because they have been encouraged to comply with the DEA regulations, and I think they're doing a relatively decent job at this point.
Well, I think they're doing a somewhat decent job, and they do have safeguards in place to identify suspicious orders. The problem is it comes down to who's employing those safeguards, how are they looking at them, and are they being overridden by an employee? Because in the end, you could have the greatest detection system in the world, but if it's not being looked at and not being, followed by the employees, we have problems. Yeah, the last 5 or 6 years, we've gone after the wholesalers and distributors because we believe that they're a major problem. There's no question. Now, we've done it by taking away their registrations and civilly fining them. That's not to say that there might not be criminal charges down the road. And in fact, if the wholesale distributor industry continues to violate over and over again, yeah, we start looking at them in a different light. But right now, I don't have to tell you, you've looked at the papers, we're taking registrations away. I know the distributors get upset and they say, oh, well, this is just, it's a patient care issue, the patients won't get their medicine. There are a lot of wholesalers out there, okay, in concentrated areas, so it really doesn't bother me that I'm taking a registration from a wholesaler, especially one that has 20 or 30 facilities throughout the country.
Well, I'm pleased to hear that. I'm sorry, just if I may. And the wholesalers that I'm talking about, these are the major players, so 3 of the biggest in the country and one of them biggest in the world for that matter. And just by way of it, for instance, there's currently a case in Southern California where a physician is being charged with multiple counts of murder and is being held. And in that particular case, for instance, I believe, based on the facts that I'm aware of, the wholesaler has just as much responsibility for having shipped thousands and thousands of OxyContin to pharmacies across Southern California that did not have a pattern of purchasing these drugs. It doesn't take very much. When you look at the numbers, you could see the numbers don't lie. The statistics are there, and this pattern continued for 3 years while this physician was under investigation. So I'm pleased to hear that wholesalers are very much on the radar screen. I just don't see that they're being prosecuted as much as pharmacists and physicians are.
And I think that may be a difference in your particular practice area. I'd refer back to Dr. Wender's question early on about cooperation between the state boards and the DEA. I think this is one of those areas where, because it involves controlled substances, or where it involves controlled substances and distributors, the Board of Pharmacy would probably expect or let the DEA take the lead on these particular kinds of cases, and that it would be more likely that there'd be DEA action against them for excessive furnishing, essentially, to pharmacies, then that the Board of Pharmacy would take action, just because the regulatory framework, I think, sets it up for it to be a little easier for the DEA to do so than for the board to do so. It's less of a sort of professional practice issue, which is what the Board of Pharmacy tends to focus on, and more a sort of numbers issue and a registration issue that the DEA can deal with more effectively, I think.
Next question.
Just wanted to refer to Dr. Wender's question with how the boards could be proactive in minimizing, I guess, diversion, addiction amongst healthcare professionals. And I know that with pharmacists, they have no trouble paying the citation or paying the fine, but to have their name appear in the quarterly pharmacy rag that comes out under disciplinary actions causes them a great deal of discomfort. And I was wondering, is there any issue with the boards as far as publication when they do take these actions of maybe giving them more prominence so that people will see if you do get caught diverting or you have problems or issues, that your face will be out there, your name will be out there, so people will know that you were party to this type of issue?
Well, my guess is with the physicians in the audience, they probably turn to in the Action newsletter to see if they know any of the cases in the back or the physicians. So there is a publication that comes out every 3 months, is that right?
Every quarter.
Every quarter from the medical board. Also, that information, although it's not available by subject matter, any of the public accusations are available online from the medical board. Look up a particular physician.
And I guess from a proactive perspective, is there being any more done to publicize it more? Because again, I see that as a deterrent personally. And just the people that I've worked with in the past, again, they would shudder at having their name out there, and probably would prevent them from doing a gray area action that might take them into a worse place if they knew that there's going to cause embarrassment for themselves, their families, things like that.
I don't think that. Oh, sorry. Go ahead. No, you please.
I was going to suggest that using the newsletter in conjunction with the physician profile on our website, so that you can actually pull up the accusation and the decision, will give you a more complete picture of what was involved, what was charged, and actually what the outcome was, and the findings of the administrative law judge. So you have the whole story on every licensee that you want to look up.
Oh no, I know the whole story's here, but letting people know that I know where to get the whole story, but a lot of consumers or others don't know where to get that story. Is there anything being done to perhaps publicize that type of thing? And again, that would be used as a deterrent for those who might be considering something inappropriate.
Okay.
I don't. The short answer to your question is no. There's nothing being considered.
That's all right.
I can give a longer answer, but I think we've satisfied
Just as a note, wait a minute.
I would like to know if there's a physician in here who is not aware of the newsletter. I mean, I think.
And I just want to say one other thing, which is that we have to remember that the point of the Practice Acts and of the board's enforcement and regulation of these professions is not to be punitive, but to protect the public. And so there's a fine line that has to be walked between making sure that the public has access to that information, yet not going out of your way so as to humiliate or spread the word about a particular individual practitioner such that we become much more punitive. Because if the laws become punitive, then they become enforced like penal laws, which means they're much more strictly construed. We want them construed broadly to protect the public. That's the main goal that we have in mind. When I'm dealing with an individual respondent or that respondent's attorney, I'd like to be able to truthfully tell that person that this is not about a moral judgment on you or about an attempt to punish you. This is about making sure that you are a professional and safe representative of your profession, and that your safe practice can be ensured for the future.
On the subject of letting the public know, my office routinely issues press releases or has press conferences on cases that would be of public interest. There have been instances where we've had a press conference because we're soliciting information from the public, and we've gotten a lot of information from people who were treated by people who were under investigation. And we do believe that that does contribute to deterrence. And there is a state statute that requires that any conviction handled by the Department of Insurance be publicized on its website, including those involving doctors.
Also, if anyone is interested in finding out what is currently happening with the medical board, any news releases or any press releases, you can become a subscriber, and invite you to go onto our website and sign up to subscribe for the kind of information that you're interested in from us.
To make sure that all pharmacists know, you're actually mandated to be a subscriber to the board's email website.
Just a note, Ken, as a pharmacist, you and I know that as soon as we get the newsletter, the first thing we do is look at the back, and we see who was disciplined and if they were in our class and if we know them, and gee, what happened. And recently, as a part of a few of our disciplinary actions, we have, especially I think with the internet issue, we've had a few pharmacists who have written newsletter articles identifying, kind of the mess that they fell into and how others could really avoid that. And I think that's been somewhat helpful. But those are kind of the two things that we currently do.
Yeah, I'm a, self-declared pain management physician in Southern California. But my question had to do with our local rag, the Los Angeles Times, just ran a series on physicians who were connected with overdose deaths. And I myself write oxycodone. I want to be certain that I'm not inflicting collateral damage anywhere. And we tried to find out if no one has ever come to me and asked me to sign a death certificate. So as far as I know, I haven't caused an overdose death, but I'd like to have access to that coroner's database and see if I have done any damage. And I'd like to know if I can how do I get access to that, like the LA Times did?
I guess you could join the LA Times.
We honestly don't know the answer to your question.
Okay, I wanted to thank everybody here. This has been a great conference. I'm so appreciative that everybody who's put it together has done so. Thank you.
Hi again, Dr. Kushner Bob. First of all, I just wanted to say, when I mentally got to the point I realized that you were doing the same purpose that I was doing, that we worked together for patient care, that's when I started becoming more and more appreciative of you. Thank God it's been quite a while now, a good 20 years, so hoorah to you. Second of all, I don't know anything about this, and I think you realize if I know about it, I'm going to speak on it. But when you do, how do I even begin? The hell hath no fury like an addict scorned. Okay? So I am sure there are addicts, and you're asking us to, as the problem gets worse, to kind of say, hey, no, slow your roll. So you're going to get more complaints about physicians, and then you're going to go look, and you're going to find, I don't know, some of them you're going to find that, they're vindicated, they're good, they did a good job. But it also points out the patient. And is there any plans in the future for the medical board or to say, hey, the patient is really screaming out for help. That's why they're making these accusations. Let's I don't know how you'd even do it, but let's go talk to them, because I think they're probably pretty high on that list. If they've gone that far, they're probably pretty high on that list of finding them in the parking lot in the morning, OD'd. So are we doing anything, or is there any plans?
I guess I'm a little unclear on your question. Are you talking about patients being the ones who
When you
complain to the board about a doctor?
You investigate a physician and you, for a complaint, and you find out that, the physician did nothing wrong. Well, and you realize that the complaint was from somebody that is addicted and they were told, no, they can't have any more drugs. Okay? Do we just stop it there, or do we somehow, I don't want to say go after the patient, but, say, hey, you've made it really obvious you got real issues here? Or do we just drop it, doctor, you're okay, go away, and then there's that patient out there floating around?
The patient receives the feedback from the investigation if we're unable to make a violation. They do get that. And we do get complaints from patients that the doctor won't give me my drugs. And sometimes it's really quite obvious that the doctor's doing the right thing. But we would take a look to see. Our complaint unit.
I didn't know you guys were doing good work.
Jeremy Adler, I'm a PA practicing down in San Diego and was a co-author on the opioid guidelines project with the American Academy of Pain Medicine. My question has to do with DEA registration. It's my understanding that registration can be lost if you provide controlled substances inconsistent with public interest. And my specific question is then, if here in California, if you provide a controlled substance, is your DEA registration at risk if the patient is known to be using a Schedule I substance, such as marijuana, considering our state has medical marijuana laws?
For a prescription to be valid, a controlled substance to be valid, in prescription form, it has to be issued for a legitimate medical purpose by an individual practitioner acting in the usual course of professional practice. You have to make a medical determination that the prescription medication, the controlled substance that you're giving to that patient, is necessary for treatment. Okay? I don't think the law takes into account whether the patient's using marijuana. Now, if the patient's a drug abuser, he's abusing that medication that you're prescribing, absolutely. Now, I can't speak for the state, but under federal law, my baseline is to ensure that you're prescribing for legitimate medical purpose, and the drug that you're prescribing is going to treat that patient, and you've made a determination that drug is necessary to treat that patient. And that's what we look at. Okay? Now, the state might look differently, and that's fine, but I can only tell you what I do under federal law. Would the state like to jump in?
Well, I mean, with the state, there are certain guidelines and protections if you're prescribing to an addict, so those would have to be taken into account. But as long as those are documented, they're not going to go after you for unprofessional conduct.
And we're talking about marijuana, right? We're not talking about, he's an oxycodone addict and you're just prescribing oxycodone.
Right. Multiple times urine drug testing has come up, which certainly I'm a strong advocate for, but you hear, well, if you're giving it to a patient and you see cocaine or methamphetamine, is marijuana being treated differently? Because scheduling-wise, it's in the same category as these other illicit, when they're used for non-medical purpose. I guess I'm listing some drugs that have legitimate medical purpose, but.
Your baseline is, and what we always look at, is that the doctor or the practitioner is prescribing for legitimate medical purpose, and he's made a medical determination, and he has a valid, bona fide doctor-patient relationship. That's what we look at. And that's what we have always looked at.
And I guess I'll add to that just one minor thing. I don't want to get into a whole discussion of medical marijuana, but I want to be clear that everyone understands that marijuana has not been legalized under California state law. It has certain things that had been crimes were decriminalized. But those are very specific and very particular. They did not remove marijuana from Schedule I or otherwise make it, a more appropriate drug than it had been previously. So you do have to be, I think you do have to take into consideration, I mean, this is really a DEA issue, but you do have to take into consideration marijuana in the same way you would any other Schedule I drug if it shows up on a tox screen.
Thank you.
And maybe there's somebody in the audience that doesn't know, it's still illegal under federal law. It's a Schedule I controlled substance.
Thank you for that, too.
And just so you know, the board has a precedential decision. If you'd like to know how you might recommend marijuana appropriately, you can go to our website and pull up that decision and read it. I think it'll give you what you need to make a good determination about whether or not you want to recommend the drug.
Jeff Liu, general internist in the trenches. And the question that preceded me is tangential to mine. After learning about cures for which I not learned or heard, and sounds like can be a very useful tool for pharmacists, physicians, and maybe even the patients. Has there been a consideration to have the cures database, the existence of the cures database posted at every pharmacy so that as patients come in, they're informed that it's entered into this database, and maybe that would give some sense of looking for a different way to get prescription narcotics. And my question about the follow-up to my predecessor was whether at any point it might be useful to have the dispensed marijuana in California entered into cures.
I'll answer the notice at pharmacies question, and I don't mean to sound flippant in this response, but I will say that the board has just gone through a lengthy process to revise its notice, the notice to consumers that is in every pharmacy currently, and anytime there's any change made to that notice, it's a sort of 2-year process. So it's very, pharmacies have very limited real estate. I don't disagree that it would be a useful thing to have patients know that they are being watched if they're receiving controlled substance prescriptions. On the other hand, you have to balance that against all of the other things that are already on the notice to consumers in pharmacies, the limited real estate. That policy judgment has never, that question's never been raised, that policy judgment has never been made, but I suspect it would run into resistance from the industry, from the pharmacy community as to where they would put that additional signage. On the second question, whether reporting of Schedule I to cures, that's sort of, you have to be clear that what is given for medical marijuana is not a prescription. So it would be an entirely new, if the whole goal is to capture medical marijuana recommendations, you would not do it by way of cures, or you would have to modify entirely the point of cures. Because medical marijuana is not dispensed in the same, you don't go to pharmacies. It would be an entirely different reporting community that would be reporting any Schedule I, but particularly medical marijuana to cures. So it's not as easy as just adding either medical marijuana or all of Schedule I to cures.
Okay.
Any other comments?
Yeah, just one more comment. The reason it's not being dispensed out of pharmacies is because it's not a medicine. Okay? So I'm just going to tell you, as a regulator, if somebody decides they want to dispense marijuana out of their pharmacy because it's a controlled substance, quote-unquote medicine, which I don't believe it is, but if you want to do that, fantastic. But don't be surprised if we come knock on your door with an immediate suspension order and take your registration. Because the reason you're not doing it by prescription is because if you do it by prescription, it's illegal. And then we're going to come after you, okay? So, this is just, it's nonsense. This is not a medicine. It's a Schedule I controlled substance. And, I get frustrated because drug evaluation, we go through such a process to evaluate something as a medicine. We do it by science. And I think Justice Souter said it best. He said, I'd rather have it by science than by referendum.
Go ahead.
Al Reeves, I'm a family physician from Ventura County. Another question with regard to the articles in the LA Times the LA Times was fairly critical of the medical board, particularly with regard to the apparent failure of the board to connect patients who were dying from drug overdoses with the physicians who had prescribed those medications, and the delay in taking action against those physicians. I wonder if the medical board is changing what they're doing or doing anything more to try to connect deaths from overdoses with the prescribers.
It wasn't, I don't think, so much a matter of not being able to connect patient to prescriber. It's not even knowing about the death itself, which is why it's my understanding that there is current legislation in the hopper to change, to allow the coroners to report, or require the coroners to report to the medical board when there is a prescription, patient who dies as a result of a prescription overdose, which was something that, although coroners are required to report to the board after making a determination there's been gross negligence, a lot of coroners are reluctant to make that call, or haven't, or are unable to make that call in connection with the prescription overdose. This particular piece of legislation, hopefully when it's finally passed through the hopper, if it gets passed, will allow us to be notified of those deaths, wherein we can backtrack and do the pairing, the connection. We can't investigate what we don't know about.
The same legislation would also require reporting to the pharmacy.
And just a comment, the medical board cannot micromanage medicine in the state. It takes what it gets reported to it and then tries to act on it. And there's sometimes, I think it's a very unrealistic idea that, you know, there's this elaborate Gestapo-like system that picks up on everything. And it reflects another issue in the state of California, and that is questionable peer review in a lot of the hospitals and clinics in California. There's some that do a great job, and others there is none.
Sorry, good afternoon. My name is Ivan Petrzelka, and I'm a pharmacist in Reading. I'd like to give the panel the opportunity to address the lack of clearly articulated standards of what does constitute a legitimate medical purpose. You know, we've seen that all in the statutes, and you know, we are basically thrown at the mercy of this standard that has never been clearly articulated or defined. And it arguably exposes both physicians and pharmacists to criminal liability, yet there really aren't any boundaries within which we should be behaving. And we briefly touched on it, you know, in previous discussions, but most importantly, if a physician provides a prescription for a controlled substance that may seem a little odd in terms of quantity or frequency of dispensing, but for the sake of discussion, let's assume that it's within reason. It's a standard, you know, same quantity for a period of months or even years for a chronic pain patient. Physicians includes diagnosis on that prescription. Where does the pharmacist as a professional stand in terms of, do I question the soundness of this diagnosis? It's chronic back pain diagnosis. I've never seen that patient in my entire life in terms of clinical examination. I've never seen his MRIs. Do I ask for the MRIs? Or where are we at in terms of how do we determine what is legitimate medical purpose and what is not?
That could be a whole day's worth of response, but I will try to limit my comments a little bit, which is, I first want to make sure that we're all on the same page in terms of understanding that there's a very specific reason, and as Joe referenced, a lot of science behind the fact that these drugs are scheduled for a reason, and that when you are dealing with controlled substance prescriptions, the expectation is that both as a prescriber and as a dispenser, you are taking a little bit of extra care with regard to those prescriptions because they are different and have different potentialities and different effects and different risks than than your standard prescription might have. That's not a controlled substance. So I sort of like to start with that baseline. And then the way that we look at a case, or the way that the investigators look at a case, is are there additional indicators on top of that that this was issued outside of a normal patient-prescriber relationship, or that it was an abuse of a patient-prescriber relationship, or that it was the prescriber may have been unaware that the prescription had been issued. Any of those things. What we're talking about is that we want you to be exercising your clinical judgment at all times, particularly with regard to controlled substances. This is not as Dr. Wender just said, this is not an indication that the Board of Pharmacy expects to micromanage every pharmacy's practice or every pharmacist's practice, and that if you have done appropriate inquiry and documented that inquiry, if you have identified in the record any red flags that you've identified and demonstrated how you have satisfied yourself that those red flags did not in fact mean that the prescription was illegitimately issued, we're not asking you to become doctors and to revise prescriptions that are legitimately issued to you, or to interfere overly much with the patient-prescriber relationship. But we do expect that you, as an additional healthcare professional with particular training in pharmacology, will exercise that training and will not say that simply because the doctor prescribed it, that means it's legitimate. That's all we're really saying, is to make sure that you are exercising your clinical judgment, taking in all information that's available to you, and making use of your ability to acquire additional information if the information record is not complete. I don't know if Judy wants to answer anything.
Thank you.
Any other comments? Okay, in the back to the left.
Yes, Bill Holdick, family physician, Visalia. One question, we recognize certain occupations have access to prescribed drugs, illicit drugs, narcotics. For example, physicians, nurses. Now, it is concerning regarding the pharmaceutical tech position. Are there background checks? Are there requirements that they are required before they become pharmaceutical techs? Is this a job that's open to anyone, even those who are felons? Are there certain restrictions?
Only minor felons.
Every license category, I believe, and there may be exceptions, but at least for these boards, every license category is required to do live scan fingerprint checks, so they would any criminal background would be recognized. Now, there may be other things that wouldn't come up on a fingerprint check that would lead you to, but there are investigations. We do deny licenses, so pharmacy technicians who have active criminal records or criminal records that are, cannot be explained, or I mean, people with criminal records can sometimes still become licensed. That doesn't, we live in a society in which we believe in second chances. We don't believe that, a mistake you made 15 years ago necessarily means that you can never seek gainful employment. But there are background checks, and people are screened for those kinds of behaviors.
If I may add, and if you look at the Code of Federal Regulations under 1301.76, it gives pharmacies are designated as practitioners. It gives guidance on what a prospective employee, what the employer should ask the prospective employee to include, prior criminal history and also drug use.
Any other comments? Lady in the back.
I have a quick question. My name is Carol, and I work for the Nursing Board for the Department of Consumer Affairs. I just wanted to ask, due to the changes that we're seeing in some of the mindset of the youth that are coming into our school systems, as far as their feelings regarding addiction, drug use, and that type of thing, medical marijuana and the things that have been allowable, and they are getting into our school systems, does the California Medical Board and or CMA, are they looking into doing an uptick in more education in substance abuse with these issues that are coming forward with this boom that's going on, this epidemic regarding prescription drugs and the like? Has there been a change, or is there an anticipated change or going on with the educational portion for physicians, pharmacists, as it relates to this type of abuse and prescription drugs and drug use?
Well, as far as education goes, I mean, the purpose of this conference is to determine how we can stop the diversion of prescription narcotics to the street and to access to schoolyards and things like that. So everything that we've been talking about and prevention, these measures are part of that process of trying to stem the tide of those drugs. As far as separate educational measures to schools or to other communities, I'm unaware of that.
If I may, for pharmacists, we have a pharmacist diversion awareness conference that we're putting on all over the country. I believe it's in June, that we're doing cooperatively with the State Board of Pharmacy. You come to this conference, you get CE credit, and we explain all different aspects of diversion, what to look for, red flags, what the drugs of abuse are, what the trends are. And that's how we're getting out the word to pharmacists, because we believe that the pharmacists are the last line of defense. And again, that's done cooperatively with the State Board of Pharmacy. But you know what's really bothering me? When we were offered the second largest school district in the country the ability to bring all of the parents in. We promoted it, we sent out blast emails, it was on the radio. 2 months before the presentation, we had 7 parents show up. Okay? Now, everyone in here, pharmacists, doctors, you could go out as a force multiplier and go to these schools and start teaching. I believe the principals in those schools would love to have you. I mean, I'm asked all the time, we go out to schools, but there's not enough of us. You're medical professionals. Who better to get in front of a class and say, hey, these drugs are dangerous, and I'm going to tell you why. And that's what we need. It's just, look at you guys. You're all in here. This is a force multiplier. You could go out and teach everything you've learned about these drugs. And it's better coming from a health professional than, a police officer like me. I mean, it's better coming from a health professional because you're trusted. Think about that. Same thing with the parents. You want to do something, go out and start teaching these parents. They don't want to come and talk obviously they didn't want to listen to us. 7 of them showed up. Maybe they'll listen to you. But that's what we need. Education is a very important component.
Excellent. Thank you.
Okay.
Yeah, thanks. My name is Bruce Olmshot. I practice in San Francisco and Palo Alto in primary care. At the end of the day, I don't know, maybe tonight I'll think, gee, I wish I would have said this, but I'm leaving here pretty frustrated. Primary care, we're stuck right in the middle. I think everyone knows that. Thank you for nodding your head. I'm seeing all of you as punitive. I'm going to get to the other side of this. I'm seeing all of you as punitive. I'm seeing you all as having this.
Leave me out of the punitive part.
Okay, thanks. No, I'm seeing you all as this list of rules that have ... that no one ever taught me. And I'm feeling like you're just waiting to pounce on me. And I know that's not true. I hope it's not true. I know that's not true. Well, when the patient comes in, I think what I've taken from the cures is it helps me to know, it helps me to get a better sense to the best that I can that my patient isn't diverting and that my patient is actually using what I'm giving him or her. If the patient is diverting or I think the patient is doctor shopping, which I just found 2 days ago, I'm still not clear what I can and cannot do based on HIPAA, and none of you wanted to even tackle it, so that leaves me not knowing what to do. And if the patient, in terms of privacy, can I talk to my colleague? Can I call the police? I guess you said yes, but you kind of all waffled on
Clearly,
it.
yes.
Clearly, yes. Thank you. So clearly I can talk to the pharmacy.
I may speak like a lawyer unintentionally, but I didn't mean to waffle.
Okay, I heard waffle. I heard waffle.
My intention was to be clear that yes, you may communicate with other healthcare practitioners,
thank you.
and yes, you may communicate with law enforcement.
Thank you. That's what I came for. And the last thing is, so if I have the patient that I really feel is dependent, pseudo-addicted, somewhere in there, but not necessarily addicted, my notes, I document. It's a double-edged sword because I say, well, I think the patient is using too much, the patient is abusing, the patient's dependent. I can try all I want to try to get them to pain management, and I keep giving them more meds in the process, as time goes along. Does that come back to haunt me? Someone just said stop giving it to them. Then they just run down the door to my colleague. So I feel frustrated, that's all. Thanks.
Well, and let me answer that. I'm the not law enforcement person. I am a huge physician advocate, and I'm a huge patient advocate. Regardless of what I do, City and County of San Francisco, we're permissibly self-insured for workers' comp. So every single one of those patients that you have are my colleagues. And every single one of them that gets into trouble and somehow finds themselves addicted to drugs simply because they didn't know they had other options or because somebody wouldn't say no, that hurts me, and it hurts our patients, and it hurts my colleagues, and it hurts their families. So what I would say to you is at some point in time, because I've been here with the occupational medicine and I've had our physicians have to go through with this, at some point in time, you're going to cross a line in your mind where you're not comfortable doing it anymore. And you're going to have to make a determination, is this something you want to keep doing because they're going to go somewhere else anyway? And at some point in time, it becomes an ethical issue, at least for me, of saying, you know, they may do that, but I'm going to make sure that I let that doctor know or the patient know that I'm going to make sure that a copy of my records get there with them. When we face this all the time in workers' comp, you almost feel like you're being blackmailed, because what that claimant says is, you know, you try and say to that doctor, you're way over the line, you aren't meeting the MTUS guidelines, and in workers' comp, we do have a little control. They say, fine, I'm going to go change doctors, and we say, you're entitled to do that, but we're going to send a cover letter to that doctor with our concerns, and we're going to send a copy of the records. That doctor can make whatever medical determination he wants to, but at least I know that I did all I could to try and get that patient back where he can get functional again.
Anybody else want to comment?
Well, I don't work for the medical board, but just assume that I did for a moment. And I'll
That's a hypothetical.
And I'll just say that if you're putting that amount of time and effort into thinking about that patient, you are not going to be the one that gets a knock from the medical board. I think one of the problems that we have as regulators, and this is sort of what Joe was saying, is that when we talk to rooms like this, we're typically talking to rooms of the good guys. People who are the outliers who would be the recipients of knocks at the door from our regulatory agencies don't tend to attend conferences like this. So, and I think the people who are the good guys are too quick to analogize what they do in their practice to what we're talking about. And there's such a vast gulf between what we're talking about and what an ordinary, prudent prescriber or pharmacist does. I don't think you can even really imagine. I don't think your brain, unless you go and read these cases, I don't think you really understand the scope of what we're talking about. And again, it's not about micromanaging pain management. I mean, we have the Intractable Pain Act. There are ways in which pain is under California law supposed to be managed, and there are guidelines for how you're supposed to do that. And if you're following all of that and crossing your T's and dotting your I's and doing your documentation, you're going to be fine. You know, I can't promise you that, but that's, you know.
He's not even one of the prosecutors.
Because I'm a lawyer.
Okay. We have about 3 minutes, so to get both of you in, it's got to be quick. Go ahead.
Just have, am I right? Yeah.
Oh, in the back. I'm sorry.
Okay, sorry.
I didn't see you.
Okay.
Go ahead.
Sorry. I just have a quick comment and questions. I tend to not see, I work in addiction psychiatry. My name is Monica Koch. And I don't see my patients, I don't separate the good guys from the bad guys. I don't separate the criminals from the not criminals. I see them all as patients. And then I see them as having individual problems where I clearly need to do due diligence. So my question for you is, other than protecting the life of a patient for suicidal or homicidal thoughts, what is it you would expect me to report to the authorities of any of my patients' behaviors? The police, law enforcement authorities.
Well, I want to be clear that we're not talking about mandatory reporting duties here.
Just double checking, yeah.
Oh, yeah. What we're talking about here are your ability to report to law enforcement if you detect criminal activity. It's no one's saying that you are, you know, I mean, you obviously that would be your defense if subsequently you are visited by the medical board or whatever to say, I did everything I could, I reported the patient, but I'm not talking about a mandatory reporting duty.
As far as the medical board's concerned, they're looking at whether their practitioners are operating within the standards of care and practice. And so unless you have evidence of something that violates that, you wouldn't be expected or to report or to.
Other than a duty to warn or whatever.
Just one more follow-up, sorry. Wouldn't that violate confidentiality? If I know my patient is selling drugs and I report this, I violate confidentiality, don't I?
You can report it to law enforcement.
Reports of criminality are not violations of confidentiality.
Okay, real quick.
Okay, real simply, I love Cures. I use it multiple times every day, and whenever I sign on to it, it says dissemination or distribution to anyone other than the registered user is strictly prohibited. So how am I supposed to call up another practitioner and say, hey, I just ran a Cures report, and guess what? There are 7 of us on there.
Ignore the fine print.
Well, I think that dissemination would mean you would be sending the Cures report off to somebody else who doesn't have doesn't
have a right to it.
The idea is that Cures you have been given specific statutory access to the Cures database for purposes of your use in diagnosis and treatment. As long as what you're doing is consistent with that, that is a perfectly acceptable use of the Cures database.
And I will report that certainly there are doctors in the community who are calling each other and saying, hey, I'm also prescribing to this patient, and that's recorded in the medical record. So it is happening.
I don't want to put any pressure on you, but you're keeping them from their break. Go ahead, Ashley.
No, I was just going to I mentioned it yesterday, but not everybody was here yesterday. I'm Barbara Showalter, a family doctor from Merced, and I had a couple of patients where anonymous people called my office and said this person is selling drugs. And about 2 weeks ago, this happened and with 2 different people, and I looked up the HIPAA statute. And it specifically said that mentioned the duty to warn, and it said if there was a criminal action such as you observe somebody stealing something from your office, you can call the police and tell them about it. But it seemed to very specifically not include talking about, I didn't feel after reading it that I could call the police and say, hey, I've got this unsubstantiated report, could you go investigate? I'm not an investigator. But you might want to look very specifically at the statute before just thinking you can not violate by talking to them, because that was my reading of it.
Well, I'm hesitant to become the lawyer to this entire group of people and give you all legal advice, but there are multiple allowances within HIPAA. You've described one of them, which is reports of criminal activity on your premises, but there are other ones, including activity that's likely to harm others or that person's self. So there are ways in which you can report activity that are not limited to the specific allowance for reporting criminality on your premises.
If we can all thank the panel for their wonderful information. We have a 15-minute break. We're on the home stretch, and so please get in and out, and we will be back at you in 15.
Oh, I'm done. I thought I was going to pass out. I've had laryngitis and the flu for.
I know, they're just asking.